slides visible?
Yes.
Yeah, so first of all, thanks Dr. Mallika ma'am and the Hyderabad Ophthalmic Association and all the panelists for giving me this chance to speak on detachments in uveitis, specifically in ARNs. Now, the thing is that we all know that detachments can occur in nearly 40 to 60% of patients with ARN. And unlike a normal routine rhegmatogenous detachment, which we encounter as vitreoretinal surgeons, the problem here in ARN is that these detachments can have both a rhegmatogenous as well as a tractional component. And when it comes to dealing with these detachments, we need to keep certain things in mind. We need to know how these detachments differ from a routine, normal, simple rhegmatogenous detachment before we start tackling them. So in the next few small video clips, I'll demonstrate how these detachments are a bit different and how we need to tackle them and what we need to do.
I think.
So the first point is pre-existing retinitis. Now, fortunately or unfortunately, whichever way we look at it, most of the cases of detachments in ARN occur once the lesions have healed. So these are detachments which happen in a healed ARN in which there is a peripheral necrotic retina. But in case you come across a patient who has got an active retinitis, you need to take care of that. Maybe given, I usually end up giving one intravitreal ganciclovir injection if there is an area of active retinitis. The reason is that if you start doing any traction over these retinitis areas, we'll end up creating more of breaks because this retina is necrotic, inflamed, and this is a retina which is more fragile. So you'll end up creating more breaks. So you need to be careful about any pre-existing retinitis. The second is abnormal vitreous additions. The vitreous in ARN eyes is a bit different from our rhegmatogenous detachments. It's more thicker. There's a higher interleukin concentration. So the vitreous over here is thicker. And if you look at this video over here, so if you see this thick sheet which is moving over here. That sheet is actually a thick band of vitreous. That is how thick these detached vitresses are. And these vitreous are abnormally adherent. So you see this peripheral areas, these peripheral areas of vitreous bands which you see over here, and these membranous bands are there, and you need to take care of them. Till you remove them, you will not be able to successfully settle your detachments. The third point is that, again, if you look at this vitreous is extremely thick. And you need to sometimes not pull it, because if you pull, you will end up creating more iatrogenic breaks. So you end up, or the ideal way is to shave them to as much you possibly and safely can. So you can go ahead with the help of a 25 gauge cutter. You can easily go underneath them and you can just truncate this vitreous, cut it as close as you can to relieve the traction. The idea is to prevent or get rid of this tendency to pull at them, because if you pull upon them, they are so thickly adherent, you will end up creating more breaks in the periphery. So you have to be careful while shaving these peripheral vitreous bands. That is a way it is different from other detachments. The third point is the fact that the peripheral retina is necrotic. So this is how the retina in a ARN RD might be. So you see this peripheral sieve-like appearance. You have got this detached retina and you see this entire peripheral retina. This is all necrotic sieve-like, multiple breaks is what you see in these eyes. So you have to remove the vitreous from it, but you have to be aware of this fact. Now there are two ways of dealing with it. Either you can do a retinectomy. Otherwise, if you even don't do a retinectomy, you can just settle the retina, because what happens is that there are dense fibroses which form. So you sometimes need not do a complete retinectomy. But you should be aware of this. This is how the peripheral retina looks like in some of these detachments. See these multiple breaks. It's just like a sieve. That's how these detachment eyes look like. The next point is ERM. Now that is another point which is there in these detachments. In ARN eyes, you have got thick ERMs, and if you do not remove them meticulously, this was a pre-op OCT of one of our patients with ERM and all of this thick membrane over there. And if you don't remove it carefully, that is one of the main reasons for recurrences which happen in these eyes. The fact is that this membrane is very thickly adherent to the retinal surface. Sometimes we might not be able to even perceive it. So now I have started post-surgery staining my retina with ILM to see, with brilliant blue, to see if there is a thick membrane which I'm missing out upon. Because then post-operatively, when you see an OCT, you will see the retina is flattened, but a shallow layer of fluid underneath which is still present. And that is because this taut membrane is not allowing the retina to settle back. So you have to carefully remove this. So this is how, see how adherent it is. And you have to very carefully remove it away. Sometimes if you're not able to remove, you might just truncate it with a cutter. And that's where the 25 gauge cutter or a 27 gauge ones, because they are so thin, you can easily go underneath these membranes and just remove them. So you try to remove as much. So this is what I did. since it was so adherent, I just truncated it and removed this adhesion over there. And then you go ahead and remove these membranes. So this is what I was talking about when I said that you have these flat, thickly adherent membranes. And till the time you remove them, you will always have this contracted retina with this traction. So once you remove this membrane, you becomes more just yeah. So once you just remove this membrane, you'll see that the retina becomes more free, more bullous, more mobile, and that is a clue to the fact that now you have been able to achieve a removal of this membrane. And the last point is doing a laser in these eyes. You have to remember that we have to do a laser in the area of the non-affected or the normal retina and not in the affected one, because if you do that, you'll end up creating more breaks. So be careful about that. Do a laser 360. I end up doing a 360-degree laser after I've settled my retina under air. And then subsequently you can use just like a normal detachment surgery, just remove the oil, air, and replace it with silicone oil. The last point is recurrence. Now again, like I said, recurrence will depend upon how carefully you have or how meticulously all the membranes have been removed. In spite of it, sometimes we do end up seeing recurrences, and in those cases you or all of us end up using a 5000 centistroke oil and leave these eyes with a long-term tamponade. But for quite a few of our patients now, we have been able to do a silicone oil removal, and on a follow-up of more than 2 to 3 years also, they are doing pretty well at this point of time. So that in nutshell sums up the challenges which we face. Now these cases are different from a normal rhegmatogenous detachment. Vitreous adhesions, necrotic retinas, and thick ERMs need to be addressed. And the last point, which actually is for all of our panel, is do you all feel that there's a role for a prophylactic laser photocoagulation in ARN? That's a question probably for the panel. Personally, my views are I don't really believe that prophylactic lasers help, because initially when they present to us, there is such a dense vitritis that we might not be able to do a laser adequately. And subsequently, if the retinitis progresses and it comes to the edge of your laser marks, then probably you'll end up having more breaks. So I do not as a rule do a prophylactic laser, but I would like to hear the opinion of our distinguished panel for this case. So thank you.